So I am Dr. Sarah Boucher. I'm a second-year concussion fellow here at the Children's Health Andrews Institute. And I'm going to be talking to you today about general information about concussions and with a big focus on how to evaluate concussions and manage those. Today, the main objectives are general overview of concussion and concussion symptoms, a review of the evaluation and diagnostic processes, and discussing the management and treatment modalities for concussions. So what is a concussion? It's a big question. You should know the basics right off the beginning. So a concussion is an injury to the head that can be caused by a direct blow, either to the head, the face, the neck, or pretty much anywhere in the body. And what that blow does is it causes a force or a jolt to the head that causes injury. A hit does not directly need to be to the head, can actually be a whiplash motion that can still cause a concussion. A linear force, something that will be a direct blow straight on the head, is actually thought to be less damaging compared to a rotational injury, which is a higher risk for injury and it can cause more severe symptoms and injury. And what a rotational force is it's typically from the side or not a direct hit. So concussion is an injury to the brain that results in temporary loss of normal brain functioning. What a concussion does is it can disrupt the communication from our brain to other systems that are really important. Our eyes, our ocular system, our vestibular system, the communication between those gets disrupted. A concussion is usually caused by a blow to the head that doesn't necessarily leave external signs. So there may not automatically be a visible injury after a hit that causes a concussion. It was once believed that a concussion, loss of consciousness equals concussion, and that there had to be loss of consciousness for concussions, but that is not the case. A majority of concussions actually do not result in loss of consciousness, so that is not, a concussion can still occur if loss of consciousness is not there. Concussion can typically affect or may affect an individual's cognitive abilities, their reflexes, their speech, their balance, and their muscle coordination. We will talk more in depth about the specific symptoms that come up, but that's just kind of a broad overview of what can be affected by a concussion. We look at it as there's no such thing as a minor or mild concussion. The injury is serious and should be taken serious when it occurs, regardless of whether it's deemed mild or minor. A second concussion after the first injury does not have to be very strong to be potentially disabling. So a second concussion may not be as bad as the first, but can still cause interference with an individual's functioning on a daily basis. Concussion is a clinical syndrome, and it's typically characterized by immediate and transient changes in brain function, and that can look like disorientation, alterations to the mental status, loss of consciousness, and those things are caused by that mechanical force or that trauma to the head or body. So just some basic statistics. About 400,000 children per year are treated in the emergency department for head injuries. Of those 400,000, about 29,000 are hospitalized, and about 3,000 result in death. Those are typically the more severe injuries that occur. An estimated 70 to 90% of concussions that receive treatment are mild, so symptoms typically resolve within a few weeks. Loss of consciousness is thought to occur in less than 10% of all concussions. So kind of going back to what I said previously, where before it was a common thought was that loss of consciousness occurred in all concussions, but it actually does not. The economic cost of concussions as a whole is estimated to be somewhere around $12 billion. In sport-related injuries and concussions are sports concussions are the second leading cause of traumatic brain injury behind motor vehicle accidents in children. So when we think of concussions, we think of who's at a higher risk for a concussion. Young children are at higher risk for concussion. The brain is still developing when we're young, so it's at a higher risk than the adult brain. And the brain develops through the early 20s. So during that period, up until then, we're more susceptible and at higher risk. Smaller neck and shoulder mass, which means less support of the head for head movements, is also kind of feeding into that higher risk as well. If you think of kids, they tend to be a bobblehead, especially as an infant. They don't have enough strength in their neck yet to kind of support their head. Also a smaller body size overall, so they absorb forces that can cause concussions differently than adults do. Females are also at higher risk for concussion. They tend to maintain a smaller body size longer, more childlike compared to males, which can increase their risk for concussion. Also, individuals with previous history of concussion are also at higher risk. The brain is already more prone to injury, and there's possibly a lower threshold of injury after they've already had a previous concussion. So they're very prone to injury if they have not completely healed from a previous concussion. So that's also something important to keep in mind. If a previous concussion is not fully healed, they're more susceptible and very prone to injury. There's one of the biggest questions that we may get is that what's the magic number to kind of stop playing sports regarding concussions and concussion history? There's no magic number of when to quit a sport. It really kind of comes down to the length of time that you have symptoms and the severity of the symptoms and any other complications when looking at long-term outcomes, but it's really difficult to predict those long-term outcomes or negative impacts. So it's not a perfect science. There's no magic number. Also, higher level of sport is also feeds into who's at higher risk. So this is kind of self-explanatory. Individuals that play sports at a higher level, college and professionally, they tend to be bigger, faster, stronger, hits are harder, there's higher force. So they are also at a higher risk. There are some sports that are also considered at higher risk. Football, soccer, hockey, and then cheerleading and gymnastics as well. Those sports tend to be more contact-based or have some level of skill that can increase the risk for contact that causes concussion. Kind of speaking a little bit more on that, sports versus concussion. So in high school sport, boys, a concussion occurs more frequently in football for males, and in females, it's soccer. Now, with that said, on this chart, on this graph here, cheerleading and gymnastics are not included. Those sports are also really susceptible to concussions, and we see a high number of concussions in those sports. So those are missing as well. So they would probably come in somewhere around soccer. So just keeping that in mind that those sports are missing here. For college sports, boys are more susceptible to concussions, or concussions occur more frequently in wrestling. And then for females, it's also soccer as well, with basketball being a close second. So what are some of the common symptoms of concussion? So these first couple that I'm going to go through are going to be the symptoms that we see initially following injury. So confusion, lack of orientation, dizziness, reduced coordination, amnesia, so difficulty with memory. These all speak to kind of those disorientation and altered mental status. Those are signs that we'll see initially after the injury occurs. Now, in the clinic are going to be the yellow circles of the symptoms that we see. So these are typically headache, fatigue, mood changes, sensitivity to light, sensitivity to noise, difficulty sleeping, either difficulty falling asleep or staying asleep, sleeping more, sleeping less, lack of energy. Inappropriate emotions is also sometimes something that parents will report noticing in their children. This kind of goes to an individual's ability to kind of manage everything at once while they're not feeling great and having difficulty kind of communicating how they're feeling. So that can kind of result in inappropriate emotions, maybe more increased irritability, frustration. So those are things to keep in mind. We don't necessarily always see that, but it is a possibility that to be aware of. So this is just another slide kind of showing some common symptoms. So physical symptoms that typically occur: headache, nausea, vomiting, dizziness, problems with balance, vision changes, fatigue, environmental sensitivities either to light or sound, more chaotic environments. Cognitive symptoms tend to be mental fogginess, or feeling slowed down, like it's harder to kind of think through things, memory problems, difficulty concentrating, and then feeling slowed down. Emotionally, individuals maybe have increased emotionality. They may be more sad, anxious, or nervous, or irritable. They may also have increased stress during this time as well, which can also add to those things. And then, as we said, sleep, trouble falling asleep, staying asleep, sleeping more than usual, or sleeping less. The signs that tend to be more observable, so things that we can see, would kind of be that loss of balance. If an individual loses consciousness, gets or blacks out, gets knocked out after an injury, is disoriented, confused, if they kind of posture and their body stiffens up after an injury, those will be the more observable signs. The symptoms that tend to be reported by individuals that we may not necessarily be able to see are more of the headache, the dizziness, feeling foggy, fatigued, having difficulties thinking, and changes to our vision. It's also important to talk a little bit about neck strain. And for that, because concussion can occur from injuries that aren't just directly to the head, but also maybe to the neck or body, we can get kind of that whiplash motion, which can lead to complaints of neck pain after the injury. It's actually fairly common for there to be neck strain or neck pain following a head injury. It's that whiplash motion that's really similar to a car wreck that can kind of get that going. So it can occur kind of immediately following the injury, or it can pop up several days later. So just because there's no neck pain immediately after does not mean that it won't come up later. Oftentimes it's mostly a muscular injury, but it's always important to inform the provider that's evaluating the individual so they can look at it and evaluate and assess it appropriately. It's important to kind of report numbness and tingling. For these injuries, you can typically try ice or heat. Over-the-counter anti-inflammatories can also be helpful for this. Neck strain, neck pain can typically resolve with a home exercise program that really focuses on stretching out that neck and targeting that area. But for some more, for longer lasting or other neck pain or strain, physical therapy may be required as well. It's also important to note red flags and emergency symptoms of concussion. These are things that should raise suspicion for a more serious or traumatic injury, like a bleed, like a hematoma within the brain. And if these symptoms are recognized or seen, an individual should be taken to the ER, or someone should call 911. So these include repetitive vomiting. Vomiting after a concussion or head injury, it's not unexpected, it's not abnormal or rare, but repetitive vomiting could potentially be an indicator of a more severe injury. So that could require further evaluation if it's repetitive. Decreased responsiveness or difficulty waking a child up, worsening headache, or kind of them reporting it's the worst headache of my life, so almost an excruciating headache, slurred speech, convulsions or seizures, blank stare, so the blank stare not being able to get their attention. This could potentially be considered an absent seizure, so also keeping an eye out for that. Unusual behavior, increasing confusion, and if the pupils are different sizes as well. All of these are immediate symptoms, and like I said, should be evaluated at an ER, in an emergency room. Some more about concussion symptoms. It's important to keep in mind that all athletes experience concussions differently. All concussions are not the same. If you've seen one concussion, you've seen one concussion, because they can be so different depending on the individual. The symptoms of concussion can help doctors kind of understand where the problem is in the brain, so we can target and focus our treatment to kind of improve those difficulties that individuals having. Symptoms of a concussion can typically get worse or better depending on school or sport activity. So physical exercise or cognitive activities can exacerbate symptoms. So that's important to keep in mind. And symptoms can get worse or better over the course of the day. What we can see is as an individual does more throughout the day, they become more fatigued because they're doing more, and that can increase symptoms as well and exacerbate them. So keeping in mind that symptoms can wax and wane. Athletes with concussions may not look or appear to be injured. We talked about observable symptoms and also the reported symptoms and signs. So just because an individual, you can't see any physical injury or physical signs does not mean that a concussion is not there, because some of these symptoms and signs of a concussion are not observable. So what do you do if you suspect a concussion? Say you're at a practice or a game, you see an athlete gets hit, a big hit to the head or a big hit to the body that creates this whiplash motion. What do you do? It's important to remove the athlete from the competition or the practice at the earliest and safest point. Especially if you start to see some of those observable signs, it'll be important to remove them so you can do an evaluation. So evaluating the individual, sideline evaluations if possible, those can be done by athletic trainers, medical providers that are on the sideline, EMTs if necessary, but it'll be important to evaluate those symptoms and then seek medical care if needed as well. So what do you do if you suspect a concussion? Say you're at a game or a practice and you see an athlete get a hit to the head or a big hit to the body that kind of creates that whiplash motion. And you start to kind of see that they're a little off, maybe they're slow to get up after the injury, maybe they're stumbling a little bit, seem confused. It's going to be important to remove that athlete from the game or the practice as soon as possible. So what do you do if you suspect a concussion? Say you're at a game, a practice, you see an athlete get a big hit to the head or a big hit to the body that creates that whiplash motion, and you notice that they're a little slow to get up, maybe they're unbalanced, seem a little confused. It's going to be very important that you take that athlete from the practice or the game. So removing them at the earliest and safest point so they can be evaluated. It's important to evaluate the individual for symptoms, especially if those observable signs are present. And that can look like a sideline evaluation, which can be done by an athletic trainer, EMT, medical providers that some teams have on the sideline with them to evaluate the individual status before letting them go back to the game or if they're able to go back. It'll also be important to seek medical care if a concussion is diagnosed after for management as well. So a sideline assessment, what does that look like? So that can be a brief assessment looking at observable and reported signs of symptoms. So if an individual is disoriented, not really aware of kind of where they are. Maybe they're having some memory difficulties, unable to kind of respond to questions, having that kind of confusion and those other observable signs of concussion. It'll be important to do a sideline assessment to rule out if there's an injury and if they're able to return. So that sideline assessment will be in addition to talking about symptoms and looking at how they're presenting, also looking at or completing a brief assessment looking for vestibular and ocular dysfunction. So what that will look like is we use the vestibular ocular motor screening, the VOMS, and that starts by assessing the baseline severity of some symptoms, specifically headache, dizziness, nausea, and fogginess, kind of that slowed down thinking process. So assessments that can be done on the sideline, these can, like I said, these can be completed by athletic trainers, medical providers that are there, or EMTs if those are available as well. But what these can typically look like is discussing symptoms that they're experiencing, and also watching for observable signs as well. So those, the trouble getting up after the injury, maybe being unbalanced or stumbling, seeming confused and disoriented. Also looking for if they're reporting headaches, dizziness, any of those other symptoms as well. Noticing how they're walking, if their gait is off, if their speech is off, if they're having difficulty responding to questions. So kind of getting and collecting that information for data for your evaluation as well. Then you can also complete a brief assessment looking for vestibular and ocular dysfunction. So we typically use the vestibular and ocular motor screening, the VOMS, which contains 5 different exercises: smooth pursuits, saccades, our ability, convergence, visual motion, sensitivity, and vestibular ocular reflex. And what you do with this is you assess for baseline severity of some symptoms prior to completing these exercises. And the symptoms that we really want to focus on getting a baseline for is headache, dizziness, nausea, and fogginess. So that slowed down thinking. So once you get your baseline, you're going to go through each exercise. But after completing each exercise, you're going to reassess each symptom. So you will have them rate on a scale of 0 to 10, with 10 being the worst, what their headache is, their dizziness, nausea, and fogginess for baseline, and then each time after the exercises. This is a provocation measure, so the provocation of symptoms or any abnormal findings can suggest dysfunction or concussion. And that by abnormal findings, looking at any changes in the eyes, if they're slowed down, maybe they're not smooth. So those types of abnormal findings that can happen. Now, that is the sideline assessment. Once an individual is evaluated on the sideline, if they believe that a concussion is present, we may see them in the clinic for an evaluation as well. So the initial clinical evaluation is different and more in-depth compared to what occurs on the sideline. The sideline is just kind of a basis to kind of determine whether they can go back into that game or practice immediately, or if they need to be evaluated further. And the important thing to keep in mind with that is when in doubt, keep them out. If they're reporting symptoms, they seem a little off, but you're questioning whether a concussion is present, it's important to just keep them out and have them evaluated further, to get a clear-cut diagnosis. So the initial clinical evaluation, so in clinic, what we typically do and what will be important is kind of getting a history of the event. So looking at the mechanism of injury, what was going on, what happened, what caused, was it a hit directly to the head? Was it a hit to the body? Was there a whiplash motion? So really getting the mechanism of injury, where they hit their head, like on the ground, a person, was it a helmet-to-helmet contact? Those details from the event will be important. Also getting information about if an individual lost consciousness, for how long, and any other symptoms that they were experiencing, and any other additional injuries as well. Was there neck pain present? Kind of what occurred during the event. Discussing current symptoms and complaints. Are they better compared to right after the injury? Are they worse? Do they seem to be the same? Kind of figuring out what's currently going on so we can go forward from there. We also do some level of neurocognitive testing, which will test the cognitive functions with specific tasks. So we typically give them multiple tasks on the first initial visit. If an individual completed baseline testing prior to the season, that can also be compared as well. But we also compare results on neurocognitive testing on subsequent follow-ups to see progress in performance over time as well. Neurocognitive testing is not necessarily a diagnostic piece, but it is a piece of the assessment puzzle. Some of the neurocognitive testing that we'll do will look at memory, reaction time, our ability to process visual information, problem solving, language, those different types of tasks so we can assess cognitive functioning. What we do in clinic is not a full neuropsychological evaluation, it's more scaled down. So it's quicker, but is still efficient in getting the information that we need. We also give them questionnaires to fill out as well. So assessing symptom scales, we use the post-concussion symptom scale to assess symptom complaints as well. Then we'll also complete a physical exam. Cranial nerves, looking at balance, any neck pain, but we also complete the VOMs in clinic as well. So going back to that vestibular and ocular motor screen, completing those 5 exercises and assessing symptom provocation from those. One of the questions that we frequently get during these evaluations is if a MRI or CT scan is necessary. And it's always a good question to ask, though one can automatically assume that that would be necessarily helpful diagnostically. An MRI or a CT scan, those are more looking at structures to show like a bleed or a tumor or or anatomy that's abnormal. What it will not kind of confirm or show if there is a concussion. So an injury to the brain from a concussion occurs entirely within the brain, and it disrupts the communication. So it really focuses on those tiny neurons and neurotransmitters, and that is what creates a concussion. And that will not show up on MRI or CT scan. So we do not automatically refer for those unless there's something in the clinical evaluation that seems to suggest it may be warranted, or if there's question if there's a structural damage as well. Those are some of the neurocognitive testing tools that we use. So once an individual is diagnosed with a concussion, the patient has a concussion, now what do we do? Great question. It's really important to know what to do afterwards. So it's really important to establish a treatment plan that will best address the needs of the individual so we can manage the concussion symptoms in the best way. What that plan and what that treatment typically looks like, it usually includes accommodations for school because symptoms can be exacerbated during cognitive activities. And what we typically see is individuals will go to school after an injury and their symptoms get ramped up significantly. So we include some accommodations for school. We also include accommodations for physical activity and recommendations for that. As well as some lifestyle modifications and just some general information that's good for brain health. And then if clinically implicated, we can refer for other specialties if an individual's recovery is prolonged or complicated, other specialties may be warranted. We can also refer for vestibular therapy at physical therapists. So like I said before, when managing concussions, it's important to remember that presentation and symptoms vary from person to person. No concussion is exactly alike. A brief period of rest may be helpful immediately following the injury, maybe about 24 to 48 hours. It was once believed that you get a concussion and you are shut down for maybe a week or for an extended period of time with doing nothing. That's a little bit different than how we manage it now. And we'll talk a little bit more about that. But maybe a brief period of rest could be helpful immediately following the injury. Management of symptoms with recognition of triggers, as well as interventions that create that relief. So those accommodations for school and activity will help with that as well. During the management of concussions, academics are our priority for student athletes. We reintroduce cognitive activities and provide accommodations that are specific to complaints that can be helpful. And depending on the course of recovery, as I stated, additional therapies may be indicated or additional specialties may be needed as well. But what we see is the average recovery time is typically 3 to 4 weeks. So we talked about how we give some accommodations for school. So what we typically do is provide athletes that are also students with return to learn paperwork and information. And it follows a progression. So as I said, academics are the priority. We want to make sure that they are able to participate in their education, and the expectation that the student is devoting as much time as possible to academics, within reason, of course, but that be the focus. While at school, symptoms are expected. You're doing more cognitive work, you're focusing more, you're requiring more out of your brain. So in terms of academic accommodations for school that we tend to provide, we provide individuals, athletes that are also students, return to learn paperwork. And it's a progression of accommodations that they can use at school that can be helpful to help manage symptoms. Like I said, academics are the priority. So the expectation is that students are devoting as much time as possible to academics, within reason, of course. But we really want to make sure that we're able to get them back to as normal of a routine as possible with that extra help. So while we're at school, we're doing a lot more cognitive work. So symptoms are expected, and it's okay. The purpose of the return to learn and the accommodations is so we can help manage those symptoms without too much of an exacerbation that it's difficult to recover from. So as we start to show, as athletes start to show more tolerance of academic activity, what we'll do is we will also start to increase physical activity and sport-specific related activity as well. Returning to learn for athletes and for students, they progress through that simultaneously as they're progressing through the return to play protocol as well, that we'll talk about in a little bit. So those two things are happening at the same time, and as they're able to tolerate more school, they're able to progress further in the return to play. A student will never be, will not fully return to sports if still requiring accommodations for concussion. As we said, academics is the priority, so that tends to be the progression that occurs faster than the return to play, or they occur at the same time. So our return to play will start off at stage 1 following the evaluation. This is for individuals that are really symptomatic, and that is typically a 90% rest and recovery and 10% academic demands. Stage 2 is 75% rest and recovery with 25% academic demands. Stage 3 is 50-50. And stage 4 is really where we start to increase the academic demands more so than the rest and recovery. So 75% academic demands with 25% recovery. And then stage 5 is where we're almost back to fully normal, about 90% or more of academic demands with 10% or less of rest and recovery. And it's important to note, as I've kind of said multiple times, is every concussion is different and every individual is different. So for return to learn, every individual may not start off at stage 1. They will be placed kind of what makes sense for their needs at that time. These are just some examples of some accommodations that can be given with some symptoms that are occurring. So some of the common symptoms that accommodations that we'll give is we'll pull back on those academic demands. So we'll give some shorter assignments, lighter workloads, allowing for breaks throughout the day, which can be really helpful in managing symptoms and preventing big overwhelming symptoms that come on at the end of the day when we're more fatigued. And those typically work with if an individual starts having symptoms or experiencing increased symptoms, they can take rest breaks at school. We typically recommend going to a quiet area like the nurse's office to let symptoms go down a little bit before returning to their academic activities. In addition to that, or there may be repetition of instructions, written instructions, reminders, verbal administration of tests and assessments, decreased screen time as well, and allowing extra time if needed. Sometimes for individuals when they have some environmental sensitivities, some of those accommodations can also be helpful, include eating lunch in a quiet place. Cafeterias tend to be pretty chaotic, which can be overwhelming. So eating in a quiet place can be more helpful, and then avoiding passing periods, which can also be pretty chaotic. In addition to this, if a student already has academic accommodations in place for like a learning disorder or for other disorders or things that they have going on, those are continued. This does not take precedent over those. This is just in addition to the accommodations they already have, especially because students with a learning disorder may require more help than normal. So having these additional accommodations can be helpful too. Now, of course, with accommodations in the school, there's going to be some challenges. So for instance, challenges with tests and quizzes. These are often, they present a heightened need for the student to perform well and achieve to be successful on. So that can put a lot of pressure. They also require more cognitive demand, more ocular motor ability, more energy and effort on the behalf of the student compared to homework and traditional classwork. So that can also be a challenge for students. So spreading tests or quizzes out across multiple sessions can help to reduce that cognitive fatigue and allow students to heal more successfully, because those things do require more cognitive effort, and with a concussion, that can be difficult for them to carry out. Also, delaying tests or quizzes until healing has occurred can result in better performance. And exempting or eliminating tests or quizzes can help keep students on pace academically without delaying recovery. What we can see happen is students becoming extremely stressed that they are falling behind or that they performed poorly on a test that they took while they had a concussion, which can complicate recovery and delay that. So we want to make sure that we give these accommodations and we take into account how much more challenging these types of activities can be when an individual has a concussion, because we want to make sure that they're performing at their best when they're being assessed on their abilities. So waiting until they're healed or delaying a little bit can be helpful. Of course, there's challenges with homework as well. So students with concussions often fatigue earlier in the day and as they do more during the day. So while at school, and they can be difficult as the day goes on, and then they'll traditionally have less energy to devote to things later in the day in that evening. So homework can be more challenging because by the time they finish their school day and they're home trying to do homework, their fatigue may be so significant and their symptoms might be exacerbated. So that's a challenge that can come up with homework. So to kind of combat that, kind of reducing the academic demands or the workload can often be accommodated by reducing the amount of homework as well, to help eliminate those challenges that come up. And then also spreading out homework across multiple days or providing students with information that would be most relevant can allow them to stay caught up or at least on pace academically. So almost eliminating or reducing the non-essential work so they can focus on what's absolutely relevant and necessary. The challenge of class attendance is also something that can come up. So core classes often present the greatest need for student participation. And as a result, exemptions may be made for students with respect to athletics and electives. As I said, academics is our priority, so we want to make sure that they're able to focus on those core classes with the least amount of difficulty as possible. So electives and athletics are typically classes that may be reduced in terms of class attendance. And things that can be helpful as well to increase tolerance of academic demands are having that reduced screen time. Now schools rely really heavily on electronics. So having pre-printed notes can provide students with increased tolerance because it also doesn't require a lot of energy or focus on traditional note-taking or staring at a computer screen for an extended period of time. Those things can be really helpful. As I said, the screen-based learning, it can really prohibit healing and can prolong it as we're staring at a screen for so long. So classes that rely on screens as a teaching method, as a primary teaching method may be more problematic. Leaving a class a little early or a little late may also allow for students to navigate the halls during classes to avoid that really chaotic, loud, kind of crazy environment that happens in passing periods. This can kind of help with vestibular difficulties that they may have that come up as well. Meeting expectations can be really challenging during this time. Concussion patients and athletes are often the students who are most involved in sports, clubs. A lot may be really high achieving kids, which can be really stressful. And the stress and demands of being a high school or middle school student today is greater than anything students have experienced to date. So it's the demands that we have on students right now is significant compared to what it was before. And stress is the #1 consumer of energy in the brain. And it's the single biggest contributor to fatigue with concussion patients. Because stress sucks out so much energy that really should be going towards focusing on recovery from concussion, it can complicate and prolong recovery. So what we want to do is we really want to make sure we're focusing on managing stress in a way that can be beneficial. So patients with concussions and athletes and students aren't so concerned and stressed out that their concussion is taking longer to heal. So we went through return to learn. As I said before, this happens simultaneously as the return to play. So as the return to sports and athletics. This is a gradual process. And as the patient improves, physical activity is increased in stepwise fashion. So looking for symptoms, symptom provocation and tolerance of those symptoms, being able to progress through this process. One of the important things to note is that avoiding contact until fully recovered is important. So allowing contact or any type of activity that can cause further injury to the head before the injury has healed can prolong the recovery process and can potentially cause additional injury. So we want to make sure that we're limiting those opportunities and avoiding contact until the concussion is fully healed. As I said before, A student won't be fully returned to sports if they are still requiring accommodations for concussion at school. Academics is the focus, so we want to make sure that most of their energy is going there rather than sports. So this happens as a stepwise process. So following the evaluation, athletes typically start at stage 1, which is limited activity. This is kind of walking around, very basic things, because the objective is recovery. This is where the majority of it is healing, but with some activity and exercise included in it. Stage 2 is when we start to include some light aerobic exercise, and the objective is to increase heart rate. So get that heart pumping a little bit faster, focusing on more cardiovascular exercise. Stage 3 is when we start to introduce sport-specific exercises, more agility-based things that are not contact-based. And this is to add movement, those quick movements. Stage 4 is, again, non-contact training, so increasing the difficulty of the drills that they're doing specifically for their sport, and to increase coordination and cognitive load. And then stage 5 is when we start to introduce some contact. So in a more controlled fashion, they can complete a full practice. And this is to restore confidence. With the return to play, it can be very sport specific. So as I said before, from every patient is different, every sport is different. So from the initial evaluation until the patient is fully cleared to return to their sport participation, every appointment, every accommodation, intervention, and recommendation is tailored towards getting them back safely to their sport and getting them back to 100% and feeling better. So sport and position-specific physical therapy may also be an option if warranted. There's dance-specific ones. There can be physical therapy specific to cheerleading and different activities like that. We also have several return-to-play protocols that are specific to sports as well, especially for sports that have less traditional activities like cheerleading and gymnastics and dance. So those plans can be more helpful with those athletes because they're able to specifically include activities that they can do at each stage that aren't necessarily common in most sports. In addition to the school accommodations and guidance for physical activity, we also provide information about general lifestyle changes that can be helpful for optimal brain health. These things are pertaining to sleep, diet, hydration, exercise, stress, and screen use. And I'm going to go through each of those ones a little bit more. So for sleep, we typically recommend 8 hours per day minimum. Sleeping at night, the full 8 hours, because that's when the most healing to the brain happens. Having good sleep hygiene habits can really be helpful to this and creating a good place for sleep. Napping should be limited because it can impact our ability to sleep at night. It may make it more difficult for us to fall asleep. We may wake up more in the middle of the night. So napping should be limited, although it can be really difficult to do so during this time because we're feeling so fatigued. When an individual has a concussion, it can really impact the sleep at night, which is when the most healing happens. So we want to make sure we're limiting those naps. More energy consumed means more sleep required. So it's like a bank, a process of deposits and withdrawals. If you take out more, you use up more money, you're going to need to put more money in. So the more sleep you get, you'll need for more energy that you consume. The more energy you consume, the more sleep that you'll need. Sleep timing is important. Eyes closed when it's dark out. So making sure that you're getting those 8 hours of sleep at night. Sleep habits can be really difficult, especially if we've had bad sleep habits for a long time. We're not born good sleepers. That's something that we become and we learn to do. So making sure that we kind of set the schedule and kind of work on good sleep hygiene habits to make sure that we're getting the best sleep possible for the recovery process. Diet is also important during this time, 3 meals per day or 5 small meals per day, but making sure we're not skipping meals. So garbage in, garbage out. We want to make sure that we're eating healthy, getting a well-balanced diet in meals, healthy snacking, so 2 to 3 healthy snacks per day, pre or post practice or competition or games. And then you want to eat for your day. So you want to eat foods that are going to have different benefits. You're going to want to have that well-balanced diet because it's going to be great for you. And the brain needs energy, which is glucose. So we want to make sure to function properly. So we want to make sure that that is happening as well. So we're getting those good meals. Hydration is going to be important as well. We recommend drinking half your body weight in ounces a day. That's typically the minimum level required of hydration. So that's going to be really important to do. Water is fine. You don't need any fancy sport drinks or fancy drinks. Drinking water is going to be sufficient to keep you hydrated. And we want to make sure we're avoiding caffeine. So a lot of caffeine is not going to be great during this time because it can really mirror the stress response in the body. And that can kind of decrease it and cause difficulty. So wanting to make sure that we're hydrated, focusing on water intake to make sure that our body is fully ready and prepared to go. So regarding stress, we talked a little bit about stress and how it can be the biggest energy grabber. So it's really important to keep it managed. And one of the ways that can be helpful in managing stress is having a consistent daily routine. Having a plan is the best way to deal with stress rather than trying to wing it as you go through the day. Communication is also key. So keeping your stress in is only going to make it grow. And it will cause it to come out when you don't want it to. If you keep it bottled up, it's going to explode and it's going to come out in ways that you're not expecting or in ways that aren't going to be helpful for you. So making sure that you're communicating going through is important. And then there's always relaxation techniques that can be helpful in managing stress. Breathing exercises, journaling, medication, and also like activities like yoga. Participating in enjoyable activities can also help manage stress as well. And then screen use. Everyone knows how big screen use is. I think myself included, I'm tied to my phone all the time. But when we're going through concussion recovery, we want to make sure that we're reducing our screen use. The smaller the screen, the worse it is. So staring at our phone for hours and hours per day is not going to be helpful. So we really always recommend no more than 2 hours per day of non-school use screens. So recreational screen use, no more than 2 hours a day. Again, because academics are our focus and that's where we want our energy going. So making sure that recreational use is more controlled, keeping in mind that the smaller the screen, the worse it is. And the farther away the screen is, the better. It's also important to keep in mind that screens may be delaying development, and eye development can occur as late as 14 to 16. So keeping that in mind as well, just in general. And then we always give recommendations about exercise. So as I said before, with concussion management, it was believed that kind of you get a concussion, you're out, you're done, resting for and out of commission for however long. We manage concussions a little bit differently now. And what we do is, what we recommend is having some exercise on a daily basis. So for ages 6 to 12, we typically recommend no more than 2 hours of rigorous exercise daily, and for kids 13 and 18, no more than 3 hours. But we do want them getting some exercise because it can help reduce stress. So having them being physically active, we do want to make sure that they're not pushing themselves too far too fast, but being active as well. And we're going to talk a little bit about the benefits in the importance of that. And so similar to other injuries and surgeries, except in other things, in that prolonged inactivity and kind of staying sedentary for a long period of time can actually have negative impacts on recovery. And so that's why we encourage some level of physical exercise. It's also been found to be helpful in decreasing symptom severity and frequency, and decreasing time needed for symptom resolution, especially when done in a controlled and supervised environment. So that's why in our return to play, in our progressions, we start with light non-contact physical activity and then progress as their symptom provocation and their management and tolerance for symptoms increases. So what some research has found is that kind of early physical activity within the first 7 days following concussion can actually be associated with lower symptom severity and then the lower duration, allowing for earlier return to school and sports. And that's why we kind of start them right off at the beginning when they see us with some level of exercise as well. We just kind of want to review the Andrews concussion model kind of from start to follow-up visits. So as we talked about, our initial evaluation is really where we focus on education and management and really where we are getting all of the information. We're completing a clinical interview to look at risk factors that may complicate recovery. We're looking at their symptom presentation, completing some neurocognitive testing, and then the vestibular and visual testing to kind of evaluate what is going on. In that, what we can see is typically individuals, there can be expedited recovery, which is typically 28 to 30 days, under 28 to 30 days. Prolonged recovery is longer than that. So during what we'll do after the initial visit is we'll come up with that treatment plan that's tailored to the individual. And then at follow-up of visits, we will kind of evaluate where they are and make any adjustments as needed. So at the first follow-up visit, if there's minimal improvement, typically the recovery is going to be longer. So expected recovery may exceed 45 days. Now at that initial follow-up visit, if there's significant improvement, but there's still some stuff going on, we'll increase the activity and participation in school and sports and then have them follow up again. Now, if an individual comes in during their first follow-up evaluation and they are kind of good to go, fully prepared to return to full activity, not reporting any symptoms, and their evaluation looks good, we'll then kind of release them to complete a return to play with their school. Okay, so just some closing thoughts and things to follow up on. So closing thoughts, brain health matters. Whether you're a coach, athlete, parent, kid, anything, proper brain health is so important to our ability to function daily. Our brain is literally what keeps us going, and that's something that will be with us for the rest of our lives. We want to make sure that we're focusing on our brain health to make sure we can function to the best of our ability on a daily basis. And it's going to be important to kind of model the brain health behavior that you want your kids, your athletes, athlete parents, anyone that you want them to have. So making sure that we're kind of doing as we say as well. It is essential and so important to recognize concussion. So becoming familiar with the signs and symptoms, the emergency signs and symptoms, and how a concussion might impact an athlete. Again, recognizing that every concussion and every individual is different, but being able to notice signs and symptoms and how it may be impacting that athlete is so important. Also having a plan, have a plan to follow a suspected concussion, and being able to recognize and know what that athlete or individual needs. And again, knowing the warning signs and when to go to the emergency department or the emergency room. Also, as I stated before, concussion, the average concussion is typically about 3 to 4 weeks to recover. So 1 in 5 concussions take about, only 1 in 5 concussions will take more than 4 weeks to recover. So we want to make sure that we are able to address all of the needs of the individual to kind of get them back and recovered and healed as fast as possible. Referral to a neuropsychologist or a specialist has been shown to be significantly faster progression through the concussion protocol into recovery. Referral to a specialist is necessary for patients that may have a more complicated recovery as well. So kind of how we talked about before, that if more specialties are needed, then they can be included and referred there for more complicated recovery. Also, those neurocognitive and the vestibular and ocular assessments that we use can provide patterns and can help us kind of anticipate or kind of create hypotheses and thoughts about what recovery time will look like following a sports concussion. So those are a really important part of our assessment process. And then those individual treatment plans are really important to managing the concussion injuries. And as I said, initial symptom severity and kind of how they're reporting and they're presenting can play a role in determining kind of what their treatment plan needs, whether there's therapy, medication, or any other possible recovery difficulties that may come up. And then just some references, and that is all I have today.